There's several chapters. Unit 9 has 29, 30, 31, and then there's chapter 32, 33, 34 that are all the antibacterial and anti-infective agents. Your text has them split up in groups as the antibiotics or anti-infectives in each group relate to each other. So I decided I'm going to do multiple mini lectures, keeping it divided the way the text did it, because I think they've done it in an excellent fashion to help you understand them. So this unit is antibacterial and anti-infective agents, and we're going to start with just chapter 29, which covers the penicillins and cephalosporins. How does it work? Why do we do them? There's multiple anti-infective drugs or antibiotics because not everything is sensitive or can kill every bacteria that's out there. So they have to isolate, do a culture, figure out the bacteria, and give an antibiotic that's appropriate for what they're trying to treat. In this image, it's showing you how antibacterials work. I thought it was a good picture because it has the different groups of the antibiotics round on this side and some things how they become resistant. So this chapter 29, is focusing right here on the beta-lactam drugs, the penicillins, is what we're going to focus on right now. But as demonstrated here, there's 5 ways that the antibacterial works against the bacteria. Like the beta-lactams, the penicillin drugs, or penicillin cephalosporins that we're going to do in this chapter, inhibit the bacterial cell wall synthesis because it has the beta-lactam rings that affect, so it causes the cell wall to start to fall apart very rapidly. The second is the membrane permeability, so more things can pass through and destroy the bacterial cell wall. Inhibit protein synthesis so that it cannot grow and metabolize. Inhibit the synthesis of RNA and DNA so it cannot grow, it can't produce energy, it cannot replicate itself. And the fifth, interference with metabolism within the cell, and that some drugs we'll cover a little later that have to do with folate production that is needed for this metabolism, so it blocks that. On this side, talking about resistance. So resistance can be because the bacteria is or is not sensitive to that. It can be a natural sensitivity or resistance, or it can be acquired. It can be acquired from too much exposure, overuse of antibiotics. So when it's been exposed to that antibacterial, it can start to alter itself. Your text gives a couple of examples of how that has occurred over time. It can also be like this, where it shows here this reflux, which is, not reflux, efflux, which is interesting, where it expands out. It can also share its resistance with other bacteria, so that's where you get into the super infections that can develop. A major cause of antibiotic resistance is listed here, from overuse of prescribing antibiotics, patients not finishing their treatment, treating, we know you should know all the foods, the fish, the chicken, especially the chicken, that are treated with antibiotics to keep them healthy and to give rapid growth, but then we're getting these antibiotics in our body gets exposed to them, and more resistance bugs form. Poor infection control in hospitals and clinics, that's what is referred to as nosocomial infections. Some terrible resistant bugs have come from that. Your text talks about them. I have actually been a nurse during the development and identification of all of these. MRSA, with the methicillin-resistant Staph aureus, and I remember when we first started seeing VRE, vancomycin resistance enterococcus. We first started seeing those in ventilator patients, and now that's something you'll get next year, talking about event-acquired infections. It is a major teaching need, opportunity, job for the nurse when people are going to take antibiotics. Cannot stress enough to take the antibiotic till it's completely gone. People routinely stop the antibiotic when they feel better. They keep some in their cabinet. They get sick and they take a little bit of it. Then they come in to the provider because they're not feeling better. Then they tell you that, oh, I had a few days of Cipro left, so I took it, which is absolutely terrible, because not every, as we'll learn, the antibacterials work in certain parts of the body because of certain bacterias that will produce or build in that part of the body. So the antibiotic that is prescribed specifically for the type of bacteria that would be in that part of the body that is infected. Antibiotics take a certain time to build up and to start to build the bacteria, so it's specifically prescribed for a certain period of time. So it's so important not to stop it. And then with all the antibiotics in our livestock and everything else, why people are trying to go organic, because it is definitely affecting our body and more immune issues are developing. So this lack of hygiene and poor sanitation, unfortunately, that's not just outside of the healthcare system, because it's in there too. So important, a simple thing of washing hands, and that's another teaching opportunity for nurses, simply washing hands and washing hands appropriately. This lack of new antibiotics being developed, they are trying to develop, your text talks about something to disable antibiotic resistant mechanism in the bacteria, which is interesting. I mean, they are trying. They've tried to do bacterial vaccines, and as noted in your text also, the vaccine for pneumococcus, which is against a bacteria, because all our other vaccines are for like viruses. So it's finally, they did do one, and hopefully there's more in the future. Okay. What kind of problems do you need to look for with taking an antibiotic? I found some things to help you remember these. If you look in your text on table 29.2, it does list these out. I just thought it was very wordy, so I put this together for you. Allergic reaction can happen with an antibiotic. It can be mild from a little rash, might be itching, could be hives. It can go all the way to edema in the mouth, the larynx, blocking off the airway, lead to bronchospasms, and loss of an airway can lead to a cardiac arrest. Sometimes it will they have to be exposed to the drug to develop a sensitivity. So first they have to be exposed. So it won't be their first dose. It's usually after about the third dose. Sometimes it doesn't happen the first time they're on the antibiotic. It'll be the second time they're on it where they develop a reaction. So you can't assume it's not due to that drug. I know I was working in Rapid Care. I was pulling some weekend shifts in Rapid Care, which is now called Fast Pace, in Pulaski. And a father brought his son in. I think his son was 9 because he was short of breath. He didn't have a rash. He had no allergies to anything. He has recently been diagnosed with strep throat and was taking amoxicillin, which we will talk about is a penicillin in the penicillin class. I talked about that, and the father kept insisting he'd been on it before. He didn't have a problem. He didn't have an allergy to it. This child started wheezing, and respiratory rate was getting more rapid. I'm thinking, is this a new onset of asthma? Nobody in the family had asthma. I went ahead and started a nebulizer treatment on him. And as the nebulizer treatment was going, I asked more questions. Father couldn't answer many, called his wife. I talked to her on the phone. Long story short, he had just taken an hour before, or a half hour before this started, he had taken his third dose of this round of amoxicillin. So he was actually having an allergic reaction to penicillin. I put my stethoscope on his throat, realized he was developing a stridor, which means his whole laryngeal area was starting to spasm. I had somebody call 911 for an ambulance, and we went to put an IV in. And if you remember from your last unit, I gave him a nebulizer with albuterol. Unfortunately, one of the side effects is constriction, so we couldn't get an IV in because of vasoconstriction. The child did get out of there, get to the hospital, everything was fine, but so I'm telling you, it doesn't mean just because they took it before, doesn't mean they might not be having an allergic reaction. I thought these statistics on adverse reactions to drugs, this mostly antibiotics, was quite large. So that's why I put that on there. Another is organ damage from organ toxicity. So I did the picture of the kidney and the liver because they're the two that are most widely effective, and I was surprised to see that liver damage, like 34%, I think it is. It's quite a lot. It's at least a third of liver damage is a result of antibiotics. And kidneys, which you'll learn more in med-surg, and then when you get into pediatrics, talking about damages to the kidney, because most of it is, some's metabolized in the liver, some's metabolized in the kidneys, but the kidney excretes the majority of the antibiotics. The last thing your text talks about is up here is the superinfection. So when somebody has immune system is down because they have an infection, they're taking an antibiotic, they're exposed to something else, they develop the bacteria develops a resistance and grows and becomes a super infection. So penicillin use. Again, your text is very good. I put this picture in just to help, because some people find pictures help them remember things. It sticks in their mind better. This was a really good picture that kind of put things together, showing the uses for the penicillin class of drugs. It is given, oh, it doesn't have an IM here. It is oral, intravenous, and intramuscular. Although it hurts very badly when you get it intramuscularly, and it smells. Okay, so your penicillin. Penicillin and cephalosporin are both referred to as beta-lactamases because of their structure. Penicillin has this cell wall beta-lactam ring, and that interferes with bacterial cell wall synthesis so that it can't have cell wall division, and it destroys. It is both bacteriostatic in that it prevents growth of bacteria, and also bactericidal in that it breaks apart that wall and kills the bacteria. Penicillin is a natural antibiotic that's derived from a mold. Over time, there have been changes. There's some bacterias that produce penicillinase, which kills the penicillin drug. There's also beta-lactamase resistant ones, bacteria. So they've come up with some changes to some of the penicillins to make them to defeat these. But in the penicillin class itself, penicillin G was the first penicillin administered orally in injection. And then penicillin V was the next time it came out. I used to go pick it up at the pharmacy and give penicillin V injections in a clinic when somebody had a terrible strep. It's a fairly cheap drug. It's a one-time dose when you can give it IM. And then the pharmacies stopped releasing it, so I could not give a one-time shot, because they said there was too many people with anaphylactic reactions to penicillin given in that route. So anyway, penicillin V is not affected by food in the stomach. So the broad spectrum, I think that's on the next slide. But you can see here, talks about the kind of things. It's pretty broad around the body of what you can treat with penicillin: in the ears, in the brain, down the throat, pneumonia, respiratory infections, septicemia, which is infection in the bloodstream, gonorrhea, UTIs, peritonitis, which is in the peritoneal cavity, infections in there. And it shows you here it inhibits the transpeptidation, I can't read that. Anyway, the reproduction to make the wall, so it breaks that wall apart, bactericidal. Okay, so this slide, the different ones that they have expanded. First, the broad spectrum penicillins. The names that are in parentheses are very helpful to help you remember what is in that class, or what they do, what they kill. So the broad spectrum, which came out first, the aminopenicillins are amoxicillin and ampicillin. There's a table in your text. 29.3, I think it is, yes. And bacterial penicillins that goes over these different and what their uses are. I would definitely review that. The broad spectrum, it covers quite a few things, and some gram-positive, gram-negative. See, E. coli is listed here. E. coli, when you saw urinary things, because it's very common to have E. coli because of the proximity of the rectum and the vagina and the ureters, urethra. Anyway, Staph aureus, which staph tends to live on our skin, so it works well on those staph infections. The next one down, penicillinase resistant penicillins, because again, there are bacteria that form this penicillinase that is resistant to penicillin. So this, calling it anti-staphylococcal, is because it fights Staph aureus. Dicloxacillin is a common one. that can be given orally. The others are only given IM. We're going to focus more on the oral in this section. This group of drugs is not effective against gram-negative organisms. The extended spectrum that fight against Pseudomonas. Excuse me. And your beta-lactamase inhibitors is your next section down. A beta-lactamase inhibitor, the most common one you've probably heard of, amoxicillin clavulanate, you would have heard of it as Augmentin. That's probably very commonly prescribed. It's because of that inhibitor with the beta-lactamase. So it's amoxicillin plus clavulanate, and the clavulanate is to fight against those inhibitors. Just the beta-lactamase inhibitor, so that the antibiotic penicillin can fight. I always refer to as Augmentin or amoxicillin clavulanate. I say it's augmented penicillin because it helps it because of the beta-lactamase issue. So as far as in your text, on table 29.3, no, go back. Chart 29.1, be familiar with some of the names of these penicillin, amoxicillin, dicloxacillins. Go down to over drug lab food interactions. You can see that there's some interaction with increased effect with aspirin, allopurinol, increased bleeding with oral anticoagulants. Come down to your labs when it talks about increase in AST, ALT. Those are your liver enzymes. Your BUN and creatinine are your kidney. So remember, I talked about the damage from antibiotics to your liver and kidney. Increased PT-INR, which is your protein and a ratio of your clotting, so it affects your clotting factors. Food decreases effect with acidic fruits or juice. So it doesn't have to be taken on an empty stomach, but you don't want to take it with like an orange juice. And therapeutic effects with the respiratory, UTI, otitis media, sinusitis. Dicloxacillin is this penicillin resistant, the anti-staphylococcus, because it works against staph. And the amoxicillin clavulanate is important. Some of the side effects, of course, all of them are potential for a superinfection, a typical superinfection for the penicillins and even the cephalosporins, which is mentioned here is vaginitis, because you get a growth of a fungal, which is a superinfection from when you're taking an antibiotic, especially penicillins and cephalosporins. Also, there's sometimes when you take different antibacterials together that one blocks the other. So tetracycline is one of those ones that you cannot take with the when you're taking penicillin, because it reduces the bactericidal effect of the penicillin. The effect of hormonal contraceptives is reduced when you're taking penicillin V or ampicillin. So it doesn't apply to all of them, so you're okay with things like amoxicillin. And it's large doses of the IV penicillins that can cause bleeding issues. Let me see if there's anything else here. Anaphylactic reactions, adverse effects such as nausea, vomiting, diarrhea. Some people can have a central nervous system effect of lethargy, anxiety, confusion. nursing, you're monitoring the vital signs, you're doing the teaching, you're watching for bleeding, you're looking for any CNS changes, central nervous system changes, your nursing diagnosis or risk for infection. If they're having adverse GI things, you're looking for a risk for dehydration or deficient volume. Let's move along here. It's just a few more slides. We're going into the cephalosporin. And cephalosporins are interesting. There are 4 classes of them, or not 4 classes, 4 generations. There was the first generation that came out, and with time they came with the second, third, and recently on the next slide you'll see they actually are working on a 5th, and I wasn't even aware of a 5th. I just knew the 4th, and your text also only speaks of the 4. So this 5th must be very, very new. So the cephalosporins are closely related to the penicillins. There's about a 10% cross-sensitivity. Cross-sensitivity means a medication that is closely related. They're not the same thing, sort of like cousins. So if you are allergic to one, hypersensitive to one, there is a 10% chance that you are hypersensitive to the other. So a lot of times I have avoided prescribing cephalosporins depending on what kind of reaction they said they had to penicillin. Some people said, oh, I have no idea. It's when I was a child. My mother told me never take it, and I have no idea. Those I'll probably give a cephalosporin. If somebody says to me, I landed in the hospital in anaphylaxis, they had to put an airway in, I'm going to avoid a cephalosporin. I'm not going to take the 10% chance. So interesting here, where I did not even know this, where your text talks about cephalosporin, a fungus called Cephalosporium acremonium was discovered in seawater at a sewer outlet off the coast of Sardinia, and it was from a fungus that was found active against gram-positive and gram-negative bacteria and resistant beta-lactamase, which is the problem we have with the penicillin, because the beta-lactamase inhibits or destroys the penicillin. So I always thought that was very interesting. I did not know how we came across the cephalosporins. So when we talk about, well, I'll probably do that in the next slide. Sorry, let me stick to this. You can see the multiple areas very close to what you saw with the penicillins of what it can treat. And that also varies by which generation you're talking about. Some significant side effects or adverse reactions. I did mean to mention that the majority of cephalosporins, not the older ones, the first and second, but as you get into the other generations, and many of the cephalosporins cannot be given orally. A few are given orally, and food does decrease the absorption rate. Not the amount that's absorbed. It doesn't block it from being absorbed, it just slows it down. But a lot of the cephalosporins are only intravenous or intramuscular, mostly intravenous. So how do they work? The first generation cephalosporins inhibit the cell wall synthesis and usually are bactericidal. So the first generation, I guess I should go to the next slide because I found this pretty cool picture here giving the names of them. If you see here, first generation, these are parenteral. That means they're given IM. And then you have the oral forms down here of the names of them. If you can see with cephalosporins, you see the CEPH or CEF. First generation is all CEPH. If it's an antibiotic that begins with a CEPH, it is a first generation cephalosporin. All the other generations of the cephalosporins, as you will notice, all start with CEF. That's one of the easier ways to try to remember them. So if you come back over here to the first generation, they are used for somebody that's allergic to penicillin, depending on how sensitive they are, treating staphylococcus and streptococcal infections, including pneumonia, cellulitis, which is a skin infection, and a bone infection called osteomyelitis. You get over here into the second generation, where everything changes to the CEF. So the second generation act against gram-negative bacteria is cefoxitin is the only cephalosporin effective against anaerobics. Those are infections that live without bacteria that grows without oxygen. Into the third, well, you'll notice here when you get to second generation, these are all parenteral or intravenous, and cefoxitin is IM also, but parenteral is just IM or IV, and there's just two that are orally. Okay, over to the third generation. Again, these are parenteral, which is IV or IM, and these are the ones that are given orally. Their third generation primarily against gram-negative organisms, and it's the drug of choice for Enterobacter, Pseudomonas, and a lot of anaerobic, the bug that lives without oxygen. The fourth generation, if you notice, both of them are only parenteral. There is no oral form. And this is one I guess they're working on here, and I'm assuming it's going to be parenteral only like the others. So the fourth generation is active against a wide range of gram-positive and gram-negative, so it's a broad-reaching antibiotic. So the cephalosporins attack bacteria. It depends. The antibacterial action of cephalosporin depend on their ability to penetrate the bacterial wall and bind the wall proteins on the cytoplasmic membrane. Drug interactions. Alcohol is a biggie. No alcoholic beverages within 72 hours of taking a dose of a cephalosporin, because it has an alcohol intolerance, which will lead to a severe headache, flushing, dizziness, nausea, vomiting, and abdominal cramps. So that is very, very important teaching of no alcohol if somebody is prescribed a cephalosporin. Adverse effects are confusion, seizure, bleeding, nausea, vomiting, diarrhea. And if you notice, that sounds exactly like what we covered with the penicillins. Some of the cephalosporins are associated with a decrease in the protein and the PTT, leading to an increased risk of bleeding. So those that are at risk are elderly, people that are more at risk for a fall. Again, just like the penicillins, the renal and hepatic or kidney and liver excretion. So you have to watch for it damaging them, because that's where it is released from the body. Hypersensitivity, the same thing, hives, itching, rash. It can be a severe reaction, anaphylaxis, but it's not as common to have anaphylaxis with the cephalosporin as it is with the penicillins. So the job of the nurse is to do the teaching, to make sure that there's not going to be an interaction, talk about the alcohol, talk about signs to report, taking it exactly as prescribed, take it till it's completely gone. It can cause some irritation in the stomach, so you may advise them to take it with some food, but not with an acidic food. Report signs of a reaction and superinfection like a fungal infection, whether it's a thrush in the mouth or a vaginitis yeast infection. No alcohol within 72 hours. I think that's about it on the cephalosporins. Let me see if there's any more in your text. Again, you have the nursing process boxes for the cephalosporins and the penicillins. I would look over those. You have a table 29.6 that goes over the different generations of them. Just be familiar with what kind of things these antibiotics would treat. And that is the end of chapter 29. Thank you.